Thank you so much, Dr. Praveen, for that introduction. Good morning, everybody. Dr. Smita, of course, in the morning, she said very nicely that, basically allergy is a hypersensitivity to insignificant normal antigens which are present either in a food or environment, which causes hypersensitivity reaction, would not otherwise affect in the normal individuals. And that is what is allergen. So when we do an allergic examination, clinical evaluation is very important, and it has to be correlated. You have to take a proper history, medical history, what has been the exposure, when do you get this kind of a rashes, or when do you get a wheeze. That becomes a very important aspect. You need to understand whether there's any seasonal variation, whether it is throughout the year, when does the patient have the symptoms of either a wheeze or a rhinitis, or could be an eczema or an urticaria. And basically and family history also, whether they've eaten something. And then of course we have to detect which is the substance which is allergic to, and then you have to plan a therapy and do basically based on the quantitative measurements. And finding a single allergen is not very easy. It is like finding a needle in a haystack. So, and there are a lot of challenges when we are doing allergy diagnosis. Coming to the history, basically the first test which was actually done for allergy was the skin pricks test, because we knew that there is a mast cell degradation and you get a wheal or a rash which is there. And later on there was characterization of IgE, and then the serological investigations came in. The first test was the RAS test, or radio allergen sorbent test. Finally, you had ELISAs, and then came an era where we started finding that there was a loss of cross-reactivity. Then came in the recombinant allergen panels, finally immunocap, and then now we have the componenter. So today we will be covering entirely the in vivo skin tests, which are still very much in vogue, the in vitro specific IgE test, and currently the new ones, which is the component resolved diagnosis for allergy. The test which is skin prick test, when you have a history, so the first test which allergologists prefer is the skin pricks test. It is the most commonly used test because it involves a direct observation of the biological response to the various allergens. So here basically you layer the volar surface of the skin, and then you look for any reaction which is there. So these could be done by puncture, intradermal techniques, which we'll talk. And why do the allergists prefer is basically because of a high sensitivity specificity. Very quick, a patient walks in with some symptom, you want to do the test within the next half an hour, then it is very easy for them. It is cost effective, it is easy to perform, but it has to be done in the presence of a good physician, because though very rare and very less cases have been reported, it is you might have an anaphylaxis to the allergen that you are doing. And it should be performed specifically, as I said, only when there is a physician which is there and who can handle any kind of an emergency. You should have a setup for that. What are the different kinds of allergic tests? Let us go into a percutaneous test, which is the common test. Here a known allergen is placed on the skin surface, and then by the help of either needles or there are applicators devices which usually transfer the allergen which is on the surface into the underlying skin, and then the results are read at a peak of reaction usually within 15 to 20 minutes after the application. You will observe a wheal response of 3 millimeter or greater, followed with surrounding erythema, and then this test should always be taken into consideration by using the controls to see whether there is a difference of at least 3 mm from the negative control, which could be just a simple saline. And these are the samples provided. You should have a proper exposure history, most convenient, as I have already said, and it depends on the skill of the individual tester, the potency of the allergen extracts which are used, the type of allergen, what kind of extracts they are, the depth of the needle puncture, duration and angle of the application device, and that is what is very important and which causes a lot of variability sometimes, and of course the patient has to go through those prick tests. But suppose you feel that the patient is, and the skin prick test is of course a very specific test, but when you feel that probably the sensitivity is not good, then you can go for higher concentrations and you can do an intradermal intracutaneous test when the tests are negative despite an adequate history of exposure and symptoms. And these are more sensitive than the percutaneous test which I mentioned, using a starting dose of about 1 in 500 to 1 in 1000. And of course, along with that, as I said, you have to have a negative and a positive control. But when you are doing a positive control, a histamine intradermal, which is a positive control, will show a response within 10 minutes, whereas the other allergens will show a response in 15 to 20 minutes. To again re-emphasize, they are thought to be more specific but less sensitive than intracutaneous or intradermal tests. And the potency will affect. Sometimes you have to do evaluation of multiple allergens, sometimes 70 or 80 pricks a patient has to undergo, which he would not like. In some food, up to 80, 100, you go on trying on it. But the good part is those allergens are easily available and you can just interact them. It becomes difficult in a patient who is a little dark, very difficult to look for the erythema, though there you can see the wheal. And then it can be where you have, in Indian population, sometimes it becomes difficult. Skin reactions can vary with age, with infants. Long-term corticosteroids, antihistaminics, tricyclic antidepressant, tranquilizers, all these can affect the skin response. So before, if you are planning for a skin prick test, you have to stop the antihistaminics. If the patient has been taking long-term corticosteroids, at least 7 days before you start doing the test, then only you will get the right kind of a response. So that is the biggest problem. And also, if you are not able to take out the antihistaminics from the patient, because then the symptoms really worse for 7 days, then you cannot do, probably you have to go in for a in vitro test. Or the eczema is so much, the patient has rash all over the skin, where is the question of you doing a test on that patient? So those are the challenges when you have with this in vivo test. So allergen provocation test, nobody really recommends, but now you do have allergen provocation test where you put in the allergen in the, once upon a time they used to do it where they used to put it under the inferior turbinate, so to see for the V's, then bronchial allergen, conjunctival, put a reagent. Not advocated. Food allergens usually they do by a patch test, only if you are thinking of a single allergen as such. So, and then you look for the reaction where you are looking for a longer time where the reaction comes within after 48 or 72 hours. Those kind of areas we do, but they are literally not being done anymore. So moving on, so as I said, there are different challenges which you have with skin prick test, intracutaneous test. So now we are going in for a in vitro test, which are the modern day tests, which gives you a quantitative assay of the specific IgE. In all of these allergy, what we are having, the testing mechanisms which are available for diagnosis are only for the specific IgE testing, because we do not really have tests for other cells which come into the place for diagnosis of allergy. So the ability to detect IgE in these patients in the presence of dermatographism, when you do not have to stop antihistaminics and you have greater safety, you just have to draw one particular skin sample from the blood sample and you are able to do multiple tests on it. So that is the advantage of the in vitro test which are done on the serum sample of a patient. So to begin with, as I said, the first test was the radioallergosorbent test where the allergen is coated onto the solid phase, and then you give, when the patient's sample is added which has the IgE antibodies, they will bind to it. A secondary antibody is formed, and then with the radio detector you measure for the radioallergen sorbent test. This because of again the risk of radiation, the permissions, these are now replaced with ELISAs, where instead of a radio-labeled antibody, you use an enzyme to detect the antigen antibody reaction, and it allows detection of various allergy-related analytes which are specific to the specific allergen, which could be a food or an inhalant, and it has a faster performance, improved biosafety when compared with radioimmunoassays, low cost, simple methodology. Even there were a lot of challenges with the extracts, the cross reactions. Then came in the fluorescent enzyme immunoassay, where instead of using an enzyme, you used a fluorochrome to measure the reaction with a fluorometer. The reaction is then measured with the concentrations of a standard curve, and you get the value of the how much is the FEIA. So these were the methods which are earlier being used, antigen antibody reactions, both the RAST, ELISA and fluorescent immunoassay. You see the specificity is pretty good with fluorescent immunoassay, and as well as the sensitivity when you compare them to the skin tests, of course, but then they have the challenges again. and they are reproducible, the fluorescent immunoassays. Automation is possible. Cost is higher for fluorescent enzyme immunoassays compared to the ELISA assays, and the shelf life of reagents is long, so we are able to use it, and hazards to the lab personnel is minimal, which you can see with radiation is there and is not there with the other techniques. But this is possible when you are thinking of a single allergy test. I am doing an ELISA, a fluorescent enzyme immunoassay. Patient gives me a history very clearly. Only when I eat eggs, I am getting reaction. Only when I get peanuts, I am getting reaction. In those kind of setups, ELISA or a fluorescent enzyme immunoassay helps. So, but that is not the case. Most of the time, when a patient has allergy, he is also not very clear, and he gives that, I'm not too sure, it could be some dal. When I'm eating this particular food, I get this. So I'm not very clear. And that is why a multiplex assay has come into the picture, where it is not a single allergen, but you look for multiple allergens. So the first assay which came was the ImmunoCap, or what is now being used by FADIA, is wherein you identification of various allergens by many specific IgE to different allergens at the same time with a minimal volume, which was the first tool characterizing, where you could detect 112 well characterized antigens. The allergens are basically coated onto this, coated by using the recombinant technology. They are usually coated onto the slide, and then it binds to the antibody. The fluorescent labeled secondary antibody is added. Then you look for the reaction which happens over there by using the automated software over there. Sorry. So that was one technique, and the other assay which became very common and very easy, but then that required a good equipment, and which is cost expensive. And later on, the immunoblot assays also came into the picture, which is being followed in many of the labs across Bangalore, in many cities, where the antigens are separated based on the molecular weight and then transferred onto a nitrocellular membrane. And it is useful in identification of relevant immunogenic epitopes after enzymatic digestion of the allergens and to identify the cross-reacting peptides. The membranes are coated with various antigens, and then a secondary antibody is added. So we do have these kind of panels, which could be an inhalant panel for those patients presenting with wheeze or asthma. There could be here, this is a complete panel of 20 antibodies, and you can see that the patient is here sensitized, or you could say allergic to both house dust mite mix and dermatophagites ferini. And this is expressed in not just as positive and negative, but they are also expressed with class intervals, and class intervals from 0 to 6. If it is a very weak, it could just be that patient has no clinical symptoms. That is one thing I wanted to say in your previous case, doctor. Probably if it was weak, very weak, it was just might have been a sensitization and would not have been the cause of the symptoms that the patient had. So that would be an important aspect to consider. And if it is a 3 or 4, then you know that there is a strong antibody reaction. This is a food panel where again you have different allergens, normal, regular, daily eating foods which suddenly cause allergy for a patient. And here see this is kind of an antibody response. Problem, it becomes, the control is of course good, so I know my band is fine, my test assay is good, but you have some mild allergy over here for potatoes, spinach, rice, then here it is showing as crab. So, but then I can see here there is something called as a CCT marker. So this indicates possibly these are insignificant, and what happens is CCT is a carbohydrate moiety which is there present on many of the cells over there. So the major challenge we find in interpreting the allergy test is the cross-reactivity. And when you say cross-reactivities, this is basically because they share amino acid sequences that can be recognized by the same IgE antibody to different allergens. And there may be for the carbohydrate moiety in the allergen. Let us just look at this. When the ELISA or any of these immunoblot assays, they use extracted allergens, there is a possibility. So here this is an indication of a carbohydrate moiety over here. This IgE, instead of it not only binds to whatever is specifically, it will go and also bind to those cells which has got this carbohydrate moiety, which gives us a false positive. So that being the thing, if at all we use recombinant molecular antigens or we block these purified antigens with a CCD inhibitor, then this can be compensated. So there are now blocking agents for this CCD to deliver, and the previous case, though it showed patterns where it could be positivity, maybe more because of CCD rather than actually a true allergy response. And that is something we need to know when we are interpreting the report. The problem with allergy is not just when we have an array of tests, it is the interpretation of the report, looking at the report properly and then understanding that becomes a challenge. This allergen cross-reactivity may not only be because of, say, the same CCDs which are there on the different cells, but it could also occur because of multiple allergens from same family, like in nut allergy or in different species. So just a few examples of how even a birch, which is a tree plant, and the apple can have a similar homologue causing a cross-reactivity. Mite or a shrimp might have, they are different. So you will come with a patient saying, I am a vegetarian. I've got house dust mite and you're telling me I'm a shrimp positive. How is that possible? Because they are having common antigens, some of them, which cause cross-reactivity, and simultaneously it shows positivity to that particular antigen. Of course, quality is very important, and there are a lot of quality programs which are there, not only the internal quality, EQUAS also is there, that is the external quality assurance. So you know globally, and when you can do harmonization of tests, how you are performing, how you compare. There are various programs, the Euroimmune has it, the UK NICAS has it. So there are multiple allergy programs which are there, and we do participate in that. So the other thing is, there are some functional assays. So can we have a functional assay? But yes, most of the functional assays can be used by flow cytometry, but not really for the regular allergens. Rather, they are being used more for adverse drug reactions, more in research and very, very specialized centers. Most of our labs do not have. And for this, usually the adverse drug reactions alone, the functional assays are done. And when a drug gives a reaction, it could be just an augmentation of a normal drug effect when it is type A, and or it could be a delayed effect, or it could be a chronic effect, or it could be a bizarre effect. So what only can be detected is mainly the bizarre effects. What is normal or delayed cannot really be detected by this functional assays, and some cases are mediated by type 1 hypersensitivity here, but other cases are and not just by IgE. So the type A reaction should be explored by the basophil activation test. So what is this test? The basophils are the ones which come into play in the drug reactions, are activated in vivo by a suspicious drug. If they are sensitized to the drug, they become active, upregulate the surface of two molecules, one is CD63 and CD203, and the cross-linking of the Fc epsilon fragment of R1 by an allergen brings these markers, the CD63 and CD203 to the surface, which is then measured by the flow cytometer. When we are doing a sample, for flow cytometric analysis, we require an EDT of blood, and we take 100 microliters of the peripheral blood, and then the drug is incubated with the blood, and then you see, and simultaneously you also use internal controls. And as I said, CD63 and CD203 are the markers, but then to ensure that there is no overlap and these are not the other markers, so to ensure that it is only a basophil, we also use HLA-DR, which is not present in basophils, and CD123, which is present in all granulocytes, and then look for the presence of, so here this is a patient which is non-stimulated, causing very low CD63, but these are the stimulated cases, and in an allergic patient, you will see that CD123 is high and CD63 is high. From negative over here, it has moved to positive, and that is what we measured in the fluorescent, in the flow cytometry. That was one aspect, but now is the new era which is coming in, and everybody is talking about component resolved diagnostics. So what is this component resolved diagnosis for allergy testing? So what we do over here is, we just said that there could be a cross-reactivity, there could be a problem. So what is, and we have understood in the last few years, we have understood because of the techniques of genetic sequencing, recombinant molecular techniques, we are able to identify which are the proteins or which is the component of the allergen which is causing the allergic reaction in a particular, say a peanut or an egg or a milk. So which are the proteins which are actually causing. So by using molecular techniques, these antigens are being, so we are able to actually these are extracted, recombinant technology, they are purified, and then we measure for them. So these single allergens can be either recombinant or natural purified and measured by either singleplex or multiplex. In general, for complex cases, is useful for more of multiple sensitization or a polysensitization to many respiratory or food allergens or even for idiopathic analysis, and it helps us in giving a specific immunotherapy. Now this is something which is we using currently, which is called as the LX2 using a component resolved diagnostics. So this is a microarray based assay where if this is a chip actually, a lab chip, biochip, in which there are about 300 allergens which have been extracted and they have been coated, and by using a recombinant DNA derived molecular technique, by using a nanotechnology so that we can identify all of these allergens at one go. And we can see 225, there are two of course for the controls, for the total IG as well as for the controls that they are present. So these go and we actually assess 295. So in this particular assay you are measuring a total IG, a specific IG and the protein component of the allergen. So, and the reporting is done by an AI driven, that is the artificial intelligence has really become a boon for all of us in diagnostics, which is automated reporting software, which takes into consideration the global, it gets networked directly to the allergy center and it comes with the report accordingly. So this really helps when you have an inconclusive clinical history, symptom profile, extract results, and in areas with high frequency of sensitization. What does this do? So this basically identifies a pan-allergen identification. There is a split. So you have, if it is a particular cockroach, you will be using BLAG1 and BLAG2. These are the two antigens, as well as BLAG7. If it is a shrimp, you have PenM2, PenM3, as well as it also has PenM1. And when it comes to dust mite, DERP1, 2, DERP7, 10, they're up to DERP10. So when you look at it, there is a cross reaction because of a few antigens. And you know which are the ones which are causing the cross reactivity. So if it is a house dust mite mix, there could be, you might get some kind of a positive with shrimp, with a cockroach, and which are the antigens which are there, which actually helps us. So this is what a component resolved diagnosis will done. Not just that, this is a house dust mite which we initially see. So it gives you which is the candidate for immunotherapy to some extent. So if the patient has DERP1 and DERP2, it is more significant and it is required that you should better to give immunotherapy. If there are other antigens which are there, possibly these do not require an immunotherapy, a sublingual immunotherapy or a skit or whatever, maybe Dr. Jay, he will be telling us better in our next section. What also it does is it gives us an understanding of the severity assessment. When we look at an egg has an egg white and egg yolk. An egg white will have these four proteins, the ova mucoid, the ova albumin, ova transferrin, and lysozymes. And the egg yolk has alpha levitin and YGP. So let us just look at this scenario. This ova mucoid is basically a very heat stable and resistant to heating and all of that, whereas these are the ones which are comparatively heat stable. And when you take a case where patient has a clinical tolerance to hen eggs despite sensitization, then you will see that the IG is definitely high, but they will usually be negative for ovomucoid, because this is the one which is causing the major problem. If the person is having a habit of eating raw eggs or half-cooked eggs instead of boiling them or cooking them, in that case, sometimes they can tolerate when they use cooked eggs, but he will give a history, but when I'm using raw eggs, I do not get. So probably the antigens which are there are ova albumin and ova transferrin, which get deactivated when you heat them. So that is one aspect. And if the patient has severe allergic reaction to egg, most likely they are ova mucoid positive and they cannot consume egg at all and can cause an anaphylaxis reaction. So this kind of an understanding we are getting with recombinant and a genetic states. Let us look at the other aspect, milk allergy. Milk has different components, caseins, lactalbumin, beta-galactoglobulin, bovine serum albumin, immunoglobulins. And of now, 4 antigens are really being seen. One is BOSD8, BOSD4, BOSD5 and BOSD6, which we are doing in our panel. But when you look, this BOSD8 is resistant to high temperatures. So even if whatever boiling you do, that will be resistant, and it indicates that there is a persistent that will cause allergy and you have to avoid. But if the patient has only allergy with BOS4 and BOS5, then in that case just heating the milk and boiling it a little will be enough, or it's in baked food, then you are able to tolerate the milk. So you can bake it and eat it. So this is the kind of a thing. Peanuts, they have multiple allergens, and it shows the increasing allergic potential and risk of severe reactions. The ones in the red are the ones which have severe allergic reaction. They are heat resistant, whereas these are a little milder, and it goes with carbohydrate profilins, PR10, the lipid transfer proteins and storage proteins. So that's how they have been. Based on that, the severity of the reaction increases. And maybe if you just roast a peanut and you have mild reaction, just ARA5, ARA8, you don't need to do anything. Just roast your peanuts and eat, and you will not have allergy. So that kind of an avoidance will help us understanding what is important. So it helps us in understanding the severity of the allergic reaction and which are the allergens which are important. And I know it is so complex, we won't even remember those names. What is ARA5, milkoid, whole thing. That is why the report comes with a very systematic, it's a big report, and interpreting it is something which you need to give a time to. But it does give you, because it connects directly to the AI, it does give you the information in the report that this is significant, this could be a cross reactivity, and this is the total IG, and this is the specific IG, and how it can help. So it helps us in actually identifying genuine versus cross reactivations. It may be useful for stratifying the patient risk, individualized guidance, and when to do therapy and how much to give therapy. So the thing is, what I would still say, see, it doesn't mean this technique has come and it has solved all our problems. We still have a lot of issues over there, understanding those reports, interpreting them, cross reactivities. It is still in the initial nascent stages that we are. Probably we'll get to know a lot more in the future. So we cannot say that this is the final over here, and we have a long way to go. But as far as asthma, and when I looked at the Indian guidelines, which has just been published in 2023, they still prefer, when it comes to the respiratory allergens, the Indian guidelines still prefer skin prick test as the best test, though not on the food. But when I looked at the global aspect, they are moving more and more into the component resolved diagnosis. So there is literally one study which says that it has actually causing an economic optimization, cost saving, because we are able to give individualized treatment to the patients. That helps the clinicians in taking a decision, and patient doesn't have to lose the working hours, not going to work, falling sick, having a wheeze. So that overall has reduced the cost for it. And as I said, though there is a long way to go, this is rapidly evolving, which makes a better understanding of the possibilities, and we can now better diagnose, prognose. However, it is very, very important to get a good clinical history, because in allergy it is very important when he gets in the morning, what are the times when he does, his previous history, his family history, what is his occupation. Because I remember one case where the patient was having, he was working in farming, and he developed allergy to one of the, silkworm. And it was the silkworm he remembers that case. So silkworm was the one, and he literally stopped that business, and he's doing very well after that. So that history is very important. And the presence of multiple reactivities, of course, still help, because we may not always get a good history, and a systematic approach with adequate history, stepwise analysis, looking at the IgE, how does the response, all that will definitely help in the diagnosis of allergy. Thank you so much.